You bend down to pick something up off the floor, and there it is. That sharp pulling in your hip, the stiff lock in your knees that wasn't there last year, the shoulder that suddenly cannot reach the second shelf, the fingers that ache in the morning for no reason at all. Your doctor calls it arthritis, or wear and tear, or just aging. Maybe she even shrugs and says, well, you're over 50 now. But what if that diagnosis is wrong? What if the pain in your joints has almost nothing to do with worn cartilage or old age, and everything to do with a system inside your body that was quietly switched off at menopause and that almost no doctor in the world is trained to recognize? In the next 16 minutes, you'll learn the real cause of the pain you've been told is permanent, and you'll learn why the solution is not what you've been told either. In 2024, an orthopedic surgeon named Dr. Vonda Wright did something nobody in mainstream medicine had managed to do in 50 years. She gave the pain a name. Dr. Wright formally defined a condition they called the musculoskeletal syndrome of menopause, MSM for short. What they documented in that paper is going to surprise you. Approximately 80% of women in the menopause transition experience significant joint, muscle, tendon, or ligament pain. Not 8%, not 18%, 80%. And of that 80%, fewer than 10% of them have any idea that what they are feeling has anything to do with their hormones. Here is why this matters more than anything else in this video. If you walk into your doctor's office today with hip pain, knee pain, frozen shoulder, finger stiffness, neck tension, or that strange whole body achiness that doesn't have a clear injury behind it, your doctor will almost certainly order an X-ray. That X-ray will show some normal changes in your joints because everyone over 50 has some normal changes. And your doctor will say, see, arthritis, wear and tear. But here is what the X-ray cannot show. It cannot show your estrogen level. It cannot show whether your joints are starving for the hormone they used your whole life to keep themselves working. So the diagnosis is structural, but the actual problem is chemical. To understand what Dr. Wright discovered, you have to understand something about your joints that almost no woman has ever been told. Every single joint in your body, your knees, your hips, your shoulders, the small joints in your hands, your spine, even your jaw, has receptors for estrogen sitting inside it. Not in the lining around the joint, inside the actual working cells of the joint. The cartilage cells, called chondrocytes, covered in estrogen receptors. The cells that make synovial fluid, your joint's natural lubricant, full of estrogen receptors. The fibroblasts that build and repair your ligaments and tendons, covered in estrogen receptors. The bone marrow cells just beneath your cartilage, same story. Now think about what this means. For your entire fertile life, estrogen was not just a reproductive hormone, it was the maintenance manager of every joint in your body. It told your cartilage cells to repair themselves. It kept your synovial fluid thick and slippery. It calmed the inflammation signals before they could damage anything. It signaled your tendons to stay flexible and your ligaments to stay strong. For 35 years, your body did this automatically. You didn't have to think about it. You didn't even know it was happening. And then, somewhere between 45 and 55, the supervisor walked out. The maintenance system did not get replaced. It just stopped. The chondrocytes stopped getting their daily instructions. The synovial fluid started thinning. The fibroblasts stopped producing the same quality of collagen. The inflammation signals, without estrogen there to suppress them, started running on full volume. And one morning, you woke up and you couldn't reach your back to fasten your bra. Or you went to stand up from a kitchen chair and felt that grinding in your knees that wasn't there last summer. Your body is not broken. Your body has been discontinued from maintenance. If you want the single most undeniable piece of evidence that this is hormonal and not structural, look at frozen shoulder. Frozen shoulder, medically known as adhesive capsulitis, is a condition where the capsule around your shoulder joint thickens, tightens, and locks the shoulder into a painfully limited range of motion. It can take a year or more to resolve, even with physical therapy. Now here is the part that should have ended the wear and tear myth a decade ago. Frozen shoulder is approximately 3 to 5 times more common in women than in men, and the peak age of onset is between 40 and 60, almost exactly the age window of perimenopause and early menopause. If this were a wear and tear problem, men would get it just as often as women. They use their shoulders the same way. They lift the same groceries. They reach for the same high shelves. But they don't. Dr. Wright's research and the wave of studies following hers point to one mechanism. The shoulder capsule is loaded with estrogen receptors. When estrogen drops, the capsule tissue undergoes a specific kind of fibrosis, thickening and scarring, that does not happen in tissues with stable hormonal support. And here is the part that should make every woman over 50 stop scrolling. The shoulder is not the only joint where this happens. It is just the joint where the change is so dramatic, so localized, and so disabling that doctors finally had to give it a name. The same fibrosis, the same inflammation, the same loss of repair signaling. It is happening more slowly and more diffusely in every other joint in your body at the same time. Frozen shoulder is not a separate condition. It is the smoking gun. It is the one joint that screamed loud enough that medicine had to listen. Now we have to talk about the part most women do not realize. The part that explains why the pain seems to come from nowhere and everywhere at the same time. Estrogen is one of the most powerful natural anti-inflammatory compounds your body produces. Specifically, estrogen suppresses three of the loudest inflammation signals in human biology: interleukin-1, interleukin-6, and tumor necrosis factor alpha. If those names mean nothing to you, here is the simple version. They are the chemical messengers that tell your immune cells to attack tissue, swell joints, and create pain. Before menopause, your estrogen kept those messengers quiet. They fired occasionally, when you sprained an ankle, when you cut your finger, and then they shut back off. After menopause, they keep firing. This is what researchers call low-grade chronic inflammation. It does not show up on a standard blood test. It does not produce a fever. It does not look like an infection. But it is happening in every tissue in your body at the same time, and your joints, with their thin cartilage and their high density of receptors, feel it more than almost anywhere else. This is the explanation for one of the most maddening symptoms women report after 50, the pain that moves around. The hip that hurts today and the wrist that hurts tomorrow. The neck that ached for a week and then handed off the ache to the lower back. It is not in your head. It is not anxiety. It is not exaggeration. It is the inflammation signal that no longer has a supervisor telling it when to stop. And the cruelest part is what this inflammation does over time. Chronic low-grade inflammation in joint tissue accelerates the breakdown of cartilage. It thickens synovial fluid into something more like syrup. It stiffens tendons. It weakens ligaments. So even though the original problem is hormonal, the inflammation slowly creates real structural damage on top of it. The X-ray, 10 years later, finally shows something. And the doctor says, "See? Arthritis." As if the arthritis was the start of the story, when in fact it was the end. This is the part of the video almost every woman over 50 needs to hear, and almost no one has said out loud. Standard musculoskeletal medicine, orthopedics, rheumatology, sports medicine is structured around imaging, X-rays, MRIs, ultrasounds. The diagnostic mindset is, show me the damaged tissue and I will name the disease. This works beautifully for a torn rotator cuff. It works beautifully for a bone fracture. It works beautifully for late-stage osteoarthritis. It does not work at all for what is happening to most women in their 50s. Because what is happening to most women in their 50s, early musculoskeletal syndrome of menopause, produces pain that is real, debilitating, and progressively worsening, but it does not yet produce any specific finding on imaging that is dramatic enough to explain it. Your cartilage shows mild thinning, which is normal for your age. Your tendons look slightly stiffer, which is normal for your age. Your bone density is borderline, which is normal for your age. Everything is normal, and nothing is fine. Dr. Wright's frustration with this gap is part of what drove her to write the MSM paper. She watched women come into her clinic year after year with real pain and watched them walk out with a shrug, a pain reliever recommendation, and the suggestion that they take up swimming. If you have been told your pain is not bad enough yet, that is a quote you should remember, because it means your doctor is waiting for damage to show up on a scan, and by the time it shows up on a scan, you have already lost 5 to 10 years of repair, signaling that nobody was even trying to restore. This is why awareness of MSM matters so much. Once you know what is happening, the conversation changes. The question stops being, is there damage? And starts being, is the maintenance system still working? Those are two very different questions, and only one of them gets asked at most appointments today. Before we get to what helps, here are the 3 signs that distinguish hormonal joint pain from structural joint pain. If 2 of these 3 apply to you, you are almost certainly dealing with something estrogen-related, not pure wear and tear. First, the pattern of the day. Hormonal joint pain is at its worst when you first get out of bed. The first 10 minutes of the morning are the worst. The pain eases as you move. By midday, you feel almost normal. Structural arthritis usually does the opposite. It gets worse the more you use the joint. Second, the symmetry. Hormonal pain shows up on both sides of the body, often in multiple joints at once. Both hips, both knees, both hands. Structural injury is usually one-sided. The knee you fell on, the shoulder you tore. Third, the timing of onset. If your joint pain started or accelerated sharply somewhere between 45 and 55, and you have no specific injury to point to, the timing alone is one of the strongest clues that the cause is hormonal. And the bonus tell, if you have already had or are currently dealing with a frozen shoulder, that by itself is one of the loudest signals that your musculoskeletal system is responding to estrogen withdrawal. 2 out of 3 is enough to take this seriously. Now what to do about it? None of these are magic. All of them are evidence-based. First, and this is the one that nobody wants to hear, resistance training. Not walking, not yoga, lifting things that are heavy enough to challenge your muscles. Multiple studies show that loading your muscles and bones 2 to 3 times a week produces a cascade of signals that partially compensate for the loss of estrogen. The mechanism involves a hormone-like molecule called osteocalcin that your bones release when you load them. It is one of the strongest interventions documented in this entire field. Second, type 2 collagen. Specifically the undenatured form, sometimes labeled UC2 in research. Multiple randomized trials show measurable reductions in joint pain and stiffness in women over 50 who supplement with it for 90 days or more. This is one of the few joint supplements that has actually held up under rigorous testing. Third, omega-3 fatty acids from fish oil. These directly suppress the same inflammation pathways, interleukin-6 and tumor necrosis factor alpha, that estrogen used to suppress for you. A dose in the range of 2 to 3 grams of combined EPA and DHA per day is what the research consistently uses. Fourth, vitamin D with vitamin K2 alongside it. Your bones cannot use calcium properly without these 2 working together, and post-menopausal women are almost universally low on both. Fifth, sleep, and specifically deep restorative sleep. Your body does most of its joint repair during the slow wave phase of sleep. If you are waking at 3 a.m., your repair window is broken. Fix the sleep first. Everything else works better when sleep works. And finally, have the conversation with a menopause-trained physician. Not a general practitioner who has never heard of MSM, a specialist who understands what Dr. Wright's work means, because the conversation about hormonal support, which is beyond the scope of this video, needs to happen with someone qualified to have it. The point is, you are not stuck with this pain. You were just never told what was actually causing it. So when someone tells you that your joints hurt because you're getting older, now you know better. Your joints hurt because the system that kept them quiet for 35 years was switched off, and nobody told you it had a name. In the next video, we are going to look at something almost no woman over 50 is warned about. The way your body changes its relationship with food, and the one specific nutrient that becomes more important after menopause than it ever was before. If you want that one, make sure you're subscribed. Take care of yourself. You earned the right to know this.